Hi, my name is Greg Kicska. I'm a cardiothoracic imager in Seattle, Washington. I work at the Veterans Affairs Hospital and University of Washington. I've been the section chief of cardiothoracic imaging at University of Washington, and I am currently the deputy chief of diagnostic imaging at the VA. I've been the president of the North American Society of Cardiovascular Imaging, and since the time I've been practicing, when I first started, linear tomosynthesis was the only type of tomosynthesis that was available in the clinical space. But shortly after I started, digital tomosynthesis became available. The film plates were replaced with digital detectors, and for the first time we were able to do tomosynthesis of the chest and musculoskeletal areas. Our institution was an early adopter, and I spent a lot of time talking with service lines about how this new technology could meet their imaging needs. I also did research on digital tomosynthesis. I designed software to test its utility in a variety of clinical scenarios. Digital tomosynthesis was exciting, but as a modality didn't change very much in the coming years. However, this past spring, Nano-X contacted me. They wanted to tell me about a new instrument that they had commercialized called the ARC. It is a digital tomosynthesis system with multiple X-ray sources. I'd never seen anything like it before, and after they showed me what it could do and what it was capable of, the images it produced, they asked me if I'd be interested in creating a lecture for imagers and clinicians to better understand it. And I said yes. I've always thought tomosynthesis is very underutilized, which is a shame because patients have a lot to gain from its appropriate use. A lecture would help people become familiar with the modality, understand how to interpret it, and think about how it best fits in for how they care for their patients. So, this is my lecture on high-resolution digital tomosynthesis using cold cathode technology. Before we get started, I would like to thank Nano-X for helping me put this lecture together. They gave me images that were taken by the Nano-X ARC, clinical histories that went along with those cases. They also gave me access to their technical team so I could learn more about the unique aspects of the instrument and understand how it works. It's also important to note that the images that I am going to show from the ARC, they were acquired under the Ethical Committee permit to conduct a clinical study in Israel. I will show some images that are not from the ARC, and they'll be labeled. So let's get started. Again, my name is Greg Kicska. I'm a cardiothoracic imager from University of Washington and the Veterans Health Administration Hospital in Seattle. And I'll be talking about cold cathode digital tomosynthesis, the evolution of high-resolution, low-dose imaging. Now, most radiologists have heard of digital tomosynthesis, but they get confused because they confuse it with linear tomosynthesis. Linear tomosynthesis is a system that most of you have seen and are familiar with. It's a big clunky system from long ago where you had an X-ray source that traveled across the patient while continuously transmitting radiation to a detector behind the patient. These systems actually would produce a series of projections that were not saved. They were simply accumulated on the detector plate, which was not digital, and it would produce an image where a single plane would be in focus. And the images looked amazing. They were 100 to 200 micron in plane resolution, and they were able to show very small urothelial lesions that you couldn't see on CT, at the time. But the problem is that you only got one plane with each acquisition. The tube as it moved from point A to B would remain focused at a certain plane. That was the plane that you hadn't focused. If you wanted to obtain another slice level, you had to repeat the acquisition and that would expose the patient to additional radiation, and there was a lot of guesswork involved. It was frustrating, but everyone knew that if you simply could have a system that would save projections through the acquisition, say using something like a large digital detector, then you'd be able to reconstruct images at any slice level you wanted. And that is what eventually happened. Flat panel detectors were, digital detectors were eventually created that had in-plane resolutions between 100 and 200 micron, and they are actually higher resolution than CT detectors. So these detectors were implemented into tomosynthesis machines. And this is how they worked. If you have a patient lying on a table, you have an X-ray source above them, and now you have a digital detector below them. If there are two objects in the patient and you are trying to see, for example, the red object without getting confused by the yellow object, which would happen in standard projection radiography, as you can see here. You create an X-ray image, and these two objects are eclipsing each other. But in tomosynthesis, you actually acquire from multiple projections, right? And those projections enable you to separate those two objects because they are present at different depths. And then what happens is, because you have saved those images, those different images that I showed you, you can recombine them and shift them to an appropriate amount where only an object at a particular level superimposes upon itself, whereas objects outside of the level are essentially blurred away because they get reproduced at multiple locations. Right? You can, of course, change the way you combine these so that instead of the yellow in the prior example, you actually have the red that is visible. And that's the magic of the digital tomosynthesis, is it's a bit like a limited angle CT. You get slices through the entire patient, but you do not completely remove the objects that are above and below the imaging plane. And those objects are often referred to as structural noise. So it gets blurred away, not entirely, but enough that the resulting images are quite useful. So this is an example of what you get with digital tomosynthesis. This is a single acquisition, and what's happening here is we are reconstructing the plane at multiple levels through the patient's foot, and you can see that the in-plane resolution is extremely high, higher than that of CT, 1 to 200 micron, and that with one acquisition you get this entire image stack. Objects that are out of plane, you can still see them, they're blurred, but they don't really confuse the anatomy of interest as much. So for many years, digital tomosynthesis didn't change. It was a single source and a digital detector. And the bulk of research that we have today on the clinical utility of tomosynthesis comes from that period. But it is common sense to be able to extrapolate those findings to new tomosynthesis technologies, like the one we're about to see. Up to this point, digital tomosynthesis had a single source, but now there is a new innovation, and I'm referring to the Nano-X arc. This is an instrument that, instead of having a gantry that slides the tube above the patient, it actually is a structure that orbits the patient and contains not one source but multiple small X-ray sources. The main innovation here with these X-ray sources, the thing that enables them to be small, is that they utilize cold cathode technology. That is a new type of X-ray tube that does not require a large power source. It can be powered with a simple plug into a 110 volt outlet, And it allows you to put multiple sources side by side above the patient so you can acquire images from those projections without having to move the source. Now, this is a versatile instrument. It can be used with abdominal imaging, chest imaging, and musculoskeletal imaging. The effective doses for each of these individual protocols is similar to that for standard radiography. And that's no surprise. That's what we usually see with tomosynthesis. I do want to point out the scan time, because that can be long in tomosynthesis. You see here for chest imaging, it's a 17-second breath hold. But because they have multiple sources, they can take advantage of that and decrease that breath hold to 13 seconds, which can make a substantial difference in patients who are short of breath. Let's talk a little bit about how it actually acquires the images, because it is interesting. There's some interesting geometries with this, and it provides opportunities for how you can position patients on the imaging equipment. So I have a picture of the Nano-X arc over here. I have the tubes labeled in red, and again, this is on this arc that goes over the patient. I've depicted that here from the side as well as the top with a patient lying on a table. The way it works is the tubes are again indicated in green dots here on this arc that goes over the patient, and when you acquire all your projections, this arc essentially tilts above the patient. While it's doing that, it is acquiring images in a variety of projection strategies. One is a linear projection strategy, where there are a series of images acquired along a line using only the central source. This is very similar to the type of digital tomosynthesis instruments that we are used to. But one interesting advantage is that there's an additional strategy where you acquire images from each X-ray source as you go over the patient. So you get this sort of matrix distribution of projections, and that is very interesting in terms of how it removes structural noise. All right, so this top projection strategy can be done with the arc, but it's what we're used to seeing with single source tomosynthesis. But something down here is only possible when you have multiple sources. All right, so how is structural noise removed with these two strategies? Well, this is how I want you to imagine it. If you have a piece of anatomy that you are interested in, and it occupies this spot right here, any anatomy that is above or below the plane of the anatomy you are interested in will be blurred in the pattern you see here for the dots, and that corresponds to the different projections. Now there are numerous projections here, and the anatomy again above and below the intensity of them will essentially get divided by the number of projections, and it will be smeared, for lack of a better word, in this type of distribution. When it comes to the matrix type pattern, that anatomy that is out of plane will get distributed in a matrix pattern, so in craniocaudal as well as right to left, or however you're placing the patient in the scanner. Let me show you an example of how this works. This is a knee tomosynthesis in a patient with a fracture of their tibia. We're not going to really focus on the fracture in this radiograph. I mean, it is an impressive fracture. But what I want to point out to you is how the metal obscures the underlying bone. Now, metal is essentially impervious to the radiograph. You see no detail behind it whatsoever. But with tomosynthesis, this is not as much a problem. So focus here on this metal. Right now, we are focused in the plane of this rod. If we move the focal plane to behind the rod using a linear pattern of acquisition, this rod, being out of plane, will be blurred in the pattern of the different projections that are acquired. And that's what's happening here. That's why you see the rod does not look as dense. It repeats in this cranial-caudal direction. And the benefit of all of this is that you can now see the anatomy behind it. So that's how the Nano-X arc works and why it's so special. It removes structural noise in chest imaging in a matrix pattern, which is not something that I've seen before. And when it comes to musculoskeletal imaging, it also is a simpler instrument. It doesn't have as much power requirements, and it is much more compact than the traditional digital tomosynthesis systems where you have the source on this large gantry mounted in the ceiling. But let's talk about some clinical cases, because it really depends on how those images actually look. I'm going to show you a variety of cases, almost all of which were taken with the Nano-X arc, and a few which were not, just to illustrate what are some of the applications for tomosynthesis. This is the case that I'd like to start with, because it does a good job of illustrating how the structural noise we see in radiographs can so easily obscure an important finding. This is an open mouth radiograph of the cervical spine in a patient with trauma. And when I look at C1 and C2, I don't see any clear abnormality. I see a lucency going across the dens, but it looks like it's probably caused by soft tissue. I would have called this normal. But let's look at what the tomosynthesis shows. Okay, so we have the radiograph here on the left. Here is a tomosynthesis series performed in the same plane. And right away you can see that the resolution of the, I should say the removal of structural noise enables you to more clearly see what is happening at specific planes. And as you choose a plane that goes through the mid-vertebral body, you can see there's a fracture at the base of the dens. Let me show you this on a CT exam, and you can see here's that fracture going through the base of the dens. There's no fracture superior to that, and that lucency that we did see doesn't really correspond to any pathology. It was probably caused by soft tissue. This advantage that you get with tomosynthesis is not unique to this specific study. Let me show you another case. This is another patient where tomosynthesis really shows how removal of structural noise can help you see fractures that are otherwise obscured on conventional radiography. This is a patient who fell onto their hands. They have a fracture. We're imaging them here after they've received a cast. Cast materials, you all know, can obscure a fracture. But in tomosynthesis, the structural noise that cast causes are essentially removed. So yes, you can see some fracture lines here on these two radiographic projections, but what you have trouble appreciating is on this tomosynthesis image, the cast material that is out of plane is essentially gone. It is not affecting lesion conspicuity, and you can see now that there is a fracture line that extends up to the joint space, which is important for classification and staging of this fracture. You can scroll through this volume and really see where the fracture lines are, whereas in an AP radiograph you're limited to fracture lines that are just well seen in that projection. Okay, here's a close-up of that same patient, and again you see fracture lines, but what you don't appreciate as clearly or as confidently is that extension of the fracture line up to the joint space,
really only possible on tomo because removal of structural noise. And some of these fracture lines can be a challenge to see on CT because remember, CT resolution is 0.6 to 0.4 at best in plane resolution, where with tomosynthesis you're looking at 0.1 to 0.2 millimeter in plane resolution. This is another case of a patient who had a fracture, and the fracture was delineated by some software here, and you can see it at the base of the metatarsal. And this would be compatible with a Lisfranc fracture. What you don't see, and tomosynthesis will show you, is that multiple fractures are in fact present. So if you look at the tomosynthesis stack, again, here's this cast material, and you move through it, you can see that you have fractures at both the base of the first metatarsal as well as at the base of the second metatarsal. And if I look up close, you can see that the fracture that we're seeing here on the sagittal CT is indeed visible very plainly here on the tomosynthesis image. And I believe if I go back, even this small fracture at the base of the first metatarsal is seen here on the tomosynthesis image. Here's that fracture of the second that we again see with better clarity here. These are not clearly seen on the radiograph, so there is this advantage of having high in-plane resolution, but also being able to reject out-of-plane noise. It isn't just fractures that this is good for. There are other applications like, for example, the detection of erosions in a wrist or a hand for the diagnosis of erosive arthritis. We all know those hand surveys that we get looking for erosive arthritis. It can be very important to determine whether a person has osteoarthritis or something like rheumatoid arthritis. Most people get radiographs because they are less expensive, they don't consume as many resources, but they are not as effective at seeing those erosions. And here's an example of that from the literature. You can see you have a standard radiograph here. In retrospect, you can see this erosion. I'm not so sure I would have identified this erosion, but when you come over to a digital tomosynthesis image, these erosions are clear. There's no confusion about them. And in one particular study, the one I'm showing you, where they looked at 30 patients with these erosions, if you use CT as a gold standard, and in their case they did, detecting 232 erosions, tomosynthesis found 199 of those, whereas standard radiography only found 140. And this is a measurable difference in accuracy of those two modalities, 71% with radiography and 83% for tomosynthesis. A similar study was also done comparing tomosynthesis to MRI, and it found the performance was similar to MRI. One of the more striking findings that I found from this study was that the agreement, the inter-observer agreement for tomosynthesis was similar to that of MRI. Radiography had very poor inter-observer agreement. Okay, let's look at this example here. Again, another fracture of the ankle. And again, you can see there's some cast material here. You can clearly see that there's a fracture of the fibula, but what's amazing to see is that there is, on the tomosynthesis image, a large fracture through the medial malleolus, which is just not seen at all on the radiograph. Here it is on CT. In some ways, I feel like it is more conspicuous on the tomo, and these were all done within a very close time frame of each other. But again, it's that ability to detect all the fractures, characterize where all the fracture lines go, and this changes how a patient should be treated whether or not they should have surgery. And tomosynthesis really clarifies a lot of these questions compared to radiography. All right, I'd like to show you some chest cases now. This case to me is very important to show. These images were not acquired with the ARC. These were acquired with a digital tomosynthesis instrument, but they illustrate an important point. We all know that lung nodules with ill-defined borders are very challenging to see on chest radiography. It is because the gradual fall off in attenuation just, without that sharp edge, it is difficult to see them. So we have a patient here with a chest radiograph, and this is a neutropenic patient. They had a fungal pneumonia. You cannot see that at all on the radiograph. Here I'm showing a single coronal image from that same patient performed at the same time, and you see several foci of fungal pneumonia. Just you can't see it on the radiograph. But tomosynthesis, again, because you remove structural noise, you increase lesion conspicuity, and on this image you can see those ill-defined nodular consolidations, 2 in the right lung. For a patient who is immunosuppressed, diagnosing a pneumonia days earlier makes a substantial difference in their mortality. And so for a patient like this, who is routinely screened with radiography, doing something like screening with tomosynthesis during periods of neutropenia, really it might be the best thing to do. All right, so I'm going to show you another case, and this is going to sort of illustrate that idea of it is the removal of structural noise that increases the conspicuity of a lesion. Unlike the case I just showed you, this patient has a very sharply defined nodule. It is partially retrocardiac. There is structural noise from edema and ribs, making that nodule difficult, not impossible, but, not as easy as it could be to be seen. All right, I'm going to zoom up here, and I'm going to show you why it is so hard to see this nodule on a radiograph. Okay, there it is. Okay, the nodule is located right there. You see it clearly on the tomo. If I draw a line across that nodule and get the attenuation numbers, all right, along that profile, you can see that as you approach the edge of that nodule, it is a very poor signal to noise. It is really hard on this graph to see that there's any discernible shelf or edge that would represent a nodule. And that is why for your eyes, it is difficult to recognize it. It is a lesion that could be missed. But in tomosynthesis, all the structural noise around that has been removed. The borders of that nodule are clearly seen. You draw a profile across it, and you just see this nice slope that represents the nodule. Yes, there's a little bit of structural noise there and a little bit of noise due to penetration, but it is superior to the radiograph image. Okay, here's that same patient that's showing the sagittal view to show you where the nodule is. And remember, it is that tomosynthesis will take all these objects behind and in front, essentially blur them out as if they're not there. You get this feeling of looking at a CT image, but the in-plane resolution is much higher. Okay, here's another patient with a pulmonary nodule. And you cannot see it on radiography. All right, this nodule here in the left lung is just is not recognized. On CT, it's clearly present, and on tomo, it is also clearly present. But that's actually not why I'm showing this case. This lesion is easily seen, but what you didn't see is that there are also very small nodules in the right upper lung. And in addition to that, there's actually a cavitary lesion that not only can you see on tomo, was not seen on radiography, but not only can you see it on tomo, but you can characterize it as a cavitary lesion confidently. That is incredibly important. I mean, it goes from having an image where you know there's an abnormality requiring further workup to having an abnormality that essentially is fully characterized. Here's another example of a lesion that you can see this one on radiography, true, but on tomosynthesis, again, you can recognize that this is a cavitary lesion, and this could represent a cavitary pneumonia. It could represent something like tuberculosis. It could also be malignancy or septic emboli, but it is that characterization of the nodule which makes a substantial difference in the value that you're getting from the imaging study. Now, recognition of pulmonary nodules has always been acknowledged as one of the strengths of tomosynthesis because you remove vessels and ribs, things that are out of plane. It makes them easier to see. One of the best studies was one that was published back in 2010 that looked at the ability of radiography and tomosynthesis to diagnose the presence of nodules. And you can see in that study the sensitivity and specificity of tomosynthesis for both readers far exceeded that of chest radiography. You had a sensitivity specificity of 91-90% versus 57 to 33% for chest radiography. But it's not just pulmonary nodules that tomosynthesis is good for in the chest. Other abnormalities, even subtle findings like this patient here who had a pleural effusion, which is, difficult to appreciate. It may not be a diagnosis that is the most important. On the lateral view, you can see that there is, you sort of lose that posterior costophrenic angle, but on the AP view, you actually can see that fat sitting between the liver and the diaphragm that lets you know that this density at the left lung base is in fact pleural fluid. Again, it's not just that. People have also looked at calcifications of the aortic arch and talking about how well tomosynthesis can identify those calcifications and give you an idea of the total atherosclerotic burden of a patient. Okay, before we finish up, I want to show two more cases of how the overlapping objects can really obscure fracture details or abnormalities, or just how tomosynthesis can remove structural noise. So this example here is a patient with a fracture of the of the distal femur. All right, and the fracture line is clearly seen on both radiography and tomosynthesis. But what I want you to look at is how all the structural noise that you get from the patella on the radiograph is absent on the tomosynthesis. It is not that far in front of the fracture lines or of the distal femur, but because of all the projections that you have and the way that that anatomy gets blurred and removed, there's no contribution to this final image, and it doesn't obscure any of the radiographic findings. All right. Here's another case. This is a patient who presented with back pain, and you can see we have, I zoomed up a section of a thoracic spine radiograph here, and I mean, I have to tell you, I would call no abnormality on this radiograph whatsoever. I'm showing you a coronal CT image here clearly there is an abnormality, there's a compression fracture of one of the vertebral bodies, you can't see that on the radiograph. But on tomo, you can see it as clearly as you can on the CT. Now, I recognize that some people who have limited experience with tomo may have intermediate confidence in calling this, but this is abnormal for a vertebral body. You can see that there's a small fracture line here, a fracture line here, so we've got 3 levels. If we look at the sagittal view, you actually can appreciate that. You can appreciate the 3 levels where a compression fracture occurred. And this really is an example of, the power of tomosynthesis. And it also illustrates how having familiarity with looking at the images, there's a misconception that just because you read CT and you read radiography, you should be able to read tomosynthesis. Yes, those skills help you, but it's a totally different modality, which speaks to its strength in showing us things that those other 2 modalities don't, and also underscores why there should be a focus on education and training in this modality, because it's worth it. There really is a lot to offer.
So those are some great cases because they really show how digital tomosynthesis provides added diagnostic value in certain clinical situations. Musculoskeletal imaging, thoracic imaging, even abdominal imaging all have particular use cases that may be best served by digital tomosynthesis compared to CT or radiography. And the Nano-X system is unique in that it does not have as large of a footprint, doesn't require as much power, and also some of the acquisition strategies utilize that matrix pattern that we discussed, which really blurs out your structural noise in a way that makes the images cleaner. I hope that going through cases like this helps people become more familiar with the modality, because I have always felt as though that's one of the major barriers to this being adopted in the clinical setting. I hope you enjoy this, and thank you very much for your time.